The opportunity to talk on this relatively obscure topic of long COVID, which has physical, societal, psychological, social impact and social symptoms. The contents of this presentation, I'll briefly be touching upon what long COVID is, what the pathophysiology lies behind and the mechanisms lying behind long COVID, what we have in the form of research evidence in the causation of long COVID, then the clinical challenges that we face in diagnosis and management, and then we will be concluding it. So a lot of terms have been used to describe long COVID. The terminology has been very varied, ranging from chronic COVID, post-acute COVID, long COVID, and so many other terminologies. And the most recent of these terminologies is PASC, which is PASC, which is post-acute sequelae of SARS-CoV-2 infection, which is being used by WHO at this moment in time. But for the sake of this presentation, I'll be using the word long COVID because it is not a tongue twister. So we first of all have to differentiate between what acute COVID is and what the sequelae arising immediately after COVID infection are, which we call as ongoing symptomatic COVID. So the symptoms of COVID lasting for up to 4 weeks, we describe them as acute COVID, and symptoms lasting from 4 weeks to 12 weeks, we label it as ongoing symptomatic COVID, which are essentially the symptoms of infection like shortness of breath, cough, and various other symptoms that we come across in acute COVID infection. On the other hand, the long COVID or post-acute COVID syndrome is are basically the persistence of these symptoms beyond 12 weeks. So all the symptoms of an acute infection and in the symptoms of post-viral syndrome arising beyond 12 weeks really. They are not explained by an alternative diagnosis. Mind you, long COVID is a diagnosis of exclusion. There are no biomarkers available to diagnose post-COVID. It's basically description and research data available to diagnose post-COVID syndrome. And it's usually a cluster of symptoms as we come across with post-viral syndromes. And these symptoms have the predilection of changing and varying with the passage of time, and their severity waxes and wanes with the passage of time. The incidence is very variable, but it is estimated that it affects nearly 10% of the whole of the population that got infected, and the numbers are in millions. For this purpose, I will just be using a meta-analysis which was published very recently in 2023, which basically pooled 54 studies and 2 medical record databases with a patient database of 1.2 million people from 22 countries. And the study findings of this meta-analysis are that vast majority of the patients who develop long COVID, they tend to get rid of their symptoms within 1 year. And another aspect was that the people who were hospitalized for acute COVID infection, they had higher chance of developing long COVID symptoms, and more severe COVID they had, more likely they were to develop long COVID symptoms. And secondly, the symptoms took longer time to disappear on those patients who got hospitalized as compared to people who were treated in the community and their homes. And surprisingly, the higher proportion of patients with long COVID are females as opposed to severe COVID, which occurred mainly in the males. So that is where perhaps the psychosocial theory comes into place. There are a lot of known factors of long COVID at the time of COVID disease, and they state, a lot of studies state that perhaps the persistent viremia in different parts of the body is the culprit in initiating autoantibodies and immunological response in the presence of already existing viral disease and perhaps reactivation of the virus like Epstein-Barr virus, and perhaps the presence of other autoantibodies in the form of connective tissue disease elsewhere, which get reactivated and they initiate the whole cascade of long COVID syndrome. And then type 2 diabetes mellitus of the clinical parameters is very grossly linked with the development of post-COVID or long COVID syndrome. The good news about vaccination is that Major General Amir Ikram very rightly has stated that we had a very robust program of vaccination. And luckily and fortunately, the full vaccination, at least 2 or 3 doses of vaccine, reduce the incidence of long COVID very significantly, as opposed to people who were not vaccinated. For this, I'll be just using a meta-analysis result which basically incorporated over 600,000 patients, and 24 studies were analyzed. And vaccine effectiveness to prevent long COVID was of the order of 37% in people who had 2 doses, and it was as high as 70% reduction in long COVID after 3 doses of vaccination. And in a nutshell, if you come to absolute terms, the incidence of developing long COVID reduced from 12 to 5.5% in people who had at least 2 or more than 2 doses of vaccination. So that is very heartening. But mind you, considering the number of phenomenal number of patients and exponential number of cases of long COVID infection, there are still people in millions who are experiencing symptoms of long COVID beyond 1 year as well. Then how are we faring in terms of various variants of long COVID? Thanks to vaccination, we believe that the risk of long COVID was nearly half that of long COVID in later variants of COVID compared to the earlier variants of COVID. For example, Delta variant patients, nearly 11% experienced long COVID, and in Omicron, which obviously is the variant that came after we have had our vaccination, and perhaps the long COVID chances, they drop down very significantly. And this holds true for all vaccine timings, whether they had vaccination 6 months ago or 1 year ago or 2 years ago before developing these symptoms and acute infections. Then there is data available. More are the acute COVID infections that you have, higher are the chances of developing long COVID. There is a significant data available, which is mainly observational data, but data from Canadian study and US Veterans Affairs study basically shows that the risk of long COVID development is directly proportional to the number of acute infections that you have. So prevention is a very good strategy here, because one of us will develop more than one infection, and we stand prone to develop long COVID in future. The symptoms of long COVID are very heterogeneous. They range anywhere from headache to skin and GI and every system in the body. But one of the commonest symptoms is the fatigue, which is a hallmark symptom of a lot of post-viral illnesses, really. Then the symptoms pertaining to the respiratory system in the form of dyspnea, shortness of breath, and brain fog, which is the cognitive impairment, headaches, and so many other symptoms. One of the hallmark symptoms is anosmia. Anosmia was seen in such high proportion of patients with COVID as has not been seen with any other viral infection in the past. So perhaps this is one of the classical symptoms. On the extreme end of long COVID, we know that myalgic encephalomyelitis and chronic fatigue syndrome, which is MECFS syndrome, occurs after a lot of viral infections, and the chances of developing, which is a very disabling symptom for a large chunk of patients. So there is a lot of evidence that perhaps myalgic encephalomyelitis and chronic fatigue syndrome is a severe form of long COVID at one end. It's like long COVID, MECFS is a syndromic disease which has symptoms very similar to long COVID. It can be perhaps precipitated by an infection, but in this case, we don't really know what the inciting infection is, as is the case with long COVID, that nearly 100% of the cases are caused by SARS-CoV-2 infection. We don't really know how many cases of CFS are there in the community, but the numbers are in millions, and it does indent the exchequer in a big way and cost billions of dollars per year. The hallmark symptom of ME/CFS and long COVID is post-exertional malaise, which is the development of malaise if you cross the exertional boundaries of a person, really, whether it's mental exertion or physical exertion, that the patients are debilitated and they develop extreme degree of malaise. And this feature is very common to both ME/CFS and long COVID as well. A lot of population-based studies do indicate that ME/CFS and long COVID symptoms are overlapping, and they are overlapping to an extent that the patients with long COVID, they fulfill the criteria of diagnosis of ME/CFS syndrome in nearly 50% of the cases, really. Then the hallmark symptom of post-exertional malaise is unique and common to both long COVID and to the other post-viral syndromes as well. And this overlapping is seen in nearly 45% of the cases in population-based studies. Then the second hallmark symptom of ME/CFS is the positional orthostatic tachycardia. On verticalization, when you stand up, you develop profound tachycardia, you develop raised heart rate, and with that you develop dizziness, and you develop a feeling of being very unwell. So this symptom is again seen in 30% of the cases with long COVID as well. So ME/CFS and long COVID, they share many similarities on biological level, and it is currently believed, though it's open to discussion, that ME/CFS may be an extreme form of long COVID. So if you come to post-viral syndromes, which we have seen in various other infections like simple influenza, to Ebola virus and West Nile virus, polio virus, or Lyme's disease, it basically is perhaps at the other end of long COVID, where you have milder symptoms compared to ME/CFS. And we know that fatigue is common, as is the case with long COVID, and multiple organ symptoms are there, as is the case with long COVID. So perhaps post-viral syndrome on one end is a lesser severe form of long COVID, and ME/CFS is perhaps at the other extreme of long COVID. One of the problems with long COVID is that it is very heterogeneous. It's heterogeneous in the sense that we haven't a consensus name for it yet. There are a lot of names have been used to describe it. Symptoms are very varied, ranging from brain to the toe, to the skin, to the GI tract or respiratory tract. Then it is heterogeneous in the sense that it involves practically every body system. And then the research approaches have been very heterogeneous, targeting on the laboratory data, targeting on the clinical parameters, and targeting on advanced data analytics, really. And then there are pathogenetic mechanisms which are different and varied. And I would divide these mechanisms into viral factors, which is the persistence and reactivation of the Epstein-Barr virus, immune dysregulation on the immune factors and autoimmunity, and tissue factors, whether it's because of the chronic inflammation in the tissues, and then the metabolic and endocrine dysregulation, which is seen in the development of type 2 diabetes mellitus. So if you do the imaging studies, MRI studies, a lot of damage is seen in a lot of body organs, really, in the form of inflammation and immune dysregulation and microbiome dysbiosis. If you look at the cardiovascular impact of long COVID, myocarditis has been a predominant eye-opener in the early parts of infection. But 1 year down the road, we have seen abnormalities in the left and right ventricular function as well. If you talk about pulmonary impact, there have been varied symptoms. And we have seen 2 years after COVID infection, there have been reduction in residual volume, in total lung capacity as well. And so is the case with the neurological system. So what are the clinical challenges? It's a difficult diagnosis to make, as there is no biomarker available. It's important to exclude other diagnoses which cause the same symptoms, but the patients have similar stories of a syndromic disease, of fatigue, and post-exertional malaise, really. So where we have got some insight into pathophysiology of long COVID, There are no curative treatments available, but it doesn't mean that we can't help our patients. We can help our patients by managing their symptoms, and that is where the allied health professionals can be very helpful in this setting. Physiotherapy can help in these patients really, but the only exception is the post-surgical malaise, which can be made worse and can cause further damage in the muscles if we do the physiotherapy. In this setting, occupational therapy is very helpful. Psychological support is very helpful, and the involvement of a psychologist is very helpful. I will take just one more minute and we'll be finishing straight away. Another symptom of shortness of breath is out of proportion to the degree of pulmonary function abnormalities, and we know that there is some evidence that autonomic dysfunction and breathing dysregulation is the culprit, and perhaps some abnormalities in the diaphragmatic function are responsible, and that is where the physiotherapy of the diaphragm might help. And for sleeping problems, simple melatonin and amitriptyline can help. The hallmark symptom of post-surgical malaise, the pacing is important. The patients, basically, it's a self-learning technique where the patients balance the exertion boundaries and the periods of rest with that. And in these cases, occupational therapy is very helpful. For POTS, which is positional orthostatic tachycardia, non-pharmacological and pharmacological treatments are available, and they can be employed. There's a very nice flow chart published in BMJ in later part of 2023, which basically takes you through the non-pharmacological and pharmacological treatment of POTS. We have a dearth of randomized controlled trials, and the only way forward is to conduct more pragmatic trials. So we have been using off-label drugs in a lot of settings based on the rationale, on the patient demand, and on the doctor sensing the underlying mechanism. So the main editors of major journals have basically come up with this publication in Lancet that there is dearth of long COVID trials in the literature, but antivirals, because of the fact that persistence of virus is perhaps the causative factor, a lot of antiviral trials are going on, and so is the case with the immune regulations trials at various levels really, and the results are expected very soon. Until we have no cure available, no biomarkers available, it's extremely important. The take-home message is to receive COVID-19 vaccination to prevent COVID infection, and then the timely use of antivirals in to prevent the development of long COVID in at-risk population, not in everybody left and right. We are talking about targeted treatment. So we conclude by saying that vaccination and antiviral treatment remain the basis of COVID-19 prevention and treatment. When I say antiviral treatment in target populations which are more vulnerable to develop long COVID infection, and they should not be used left and right in every patient with mild to moderate COVID infection really. So we know that it's a heterogeneous disease, and we need to understand the immunological and pathophysiological mechanisms underlying it. And until we have a better understanding of the phenotyping, the prerequisites for therapeutic development will take time to develop, and I do hope that they will develop in very near future. Thank you very much, and sorry for overshooting my time by a minute.
Thank you very much, Professor Saqib Saeed.